Good evening, everyone. My name is Carver. I am a product specialist here at Oculus. Welcome to tonight's clinical webcast, Scleral Lens Bootcamp with Dr. Ken Mahler. You have a text box on your GoToWebinar screen where you can enter questions. Feel free to enter your questions during or immediately after the presentation, and we'll have some time to discuss them at the end of tonight's webcast. Our speaker tonight is Dr. Ken Mahler. Dr. Mahler earned his doctorate from the Illinois College of Optometry and is currently in practice in Fort Lauderdale, Florida. His practice is devoted to orthokeratology as well as providing visual rehabilitation for the irregular cornea. He is one of the foremost wave contact lens designers in the world and authored the first wave contact lens designer certification program. Dr. Mahler lectures extensively on custom contact lens design as well as providing clinical consultation services. Dr. Mahler was also one of the first doctors to start using the Pentacam corneal skull profile scan, or CSP software, including when it was still in beta 2 years ago. He is a fellow in the American Academy of Optometry, a fellow in the International Academy of Orthokeratology, a diplomat in the American Board of Optometry, and a fellow in the Scleral Lens Society. It's an honor to have Dr. Mahler here with us tonight for this webcast, and on behalf of Oculus, I would like to express our gratitude for your time and effort. I would also like to thank you all in attendance tonight for your time. Without further delay, I'd like to welcome Dr. Ken Mahler.
Hello there. Good evening to you all, and thanks for coming to attend the Scleral Lens Bootcamp webinar that I'm doing here tonight. This lecture came about as an idea from the last webinar that I had done, indicating that a lot of the listeners who had attended the last webinar were really still asking much more basic questions, and so I've put this lecture together here to hopefully get people kind of a foundation on scleral lenses, how to the hows and whys of using scleral lenses, and also how to be able to go about prescribing using scleral mapping technology as a CSP allows you to have. Okay, so without further ado, let's move right on here, and there we go. First, as a disclosure here, Oculus is paying me, but I am not paid by Wave. Wave is a software platform, and I am going to be talking about that here later in the lecture. My practice is devoted to irregular corneas and orthokeratology. I'm in solo private practice, and I don't really do anything else. It's rare that I do even a general primary care exam. I'll do one or two here or there type of thing, but for the most part, my day-to-day is consisting of irregular corneas and ortho-K. I have done national support for Wave. That's going back probably about 15 years ago. I do lecture on Wave extensively, and I also do offer consultation services on a private basis with docs around the country. Either I will do some of their cases for them, either right from the start, or it may be a case that had gotten into trouble and they needed me to bail them out. I also do more formalized one-on-one training to get them up and running by giving them both information about Wave and how to approach some of the cases, and being able to design the lenses. I still do beta testing for Wave as the newer versions come out, although it is a very mature program now. It's probably about 20 years old now, and I did author the Wave Designers, the certification program, as well as I did do an entire Wave training weekend a few years ago that is still actually available on DVD from my website. As you can see, I put a big sign here. Please do not wait for the end to submit questions. By all means, type them in. The moderator, Carver, he will be able to get those to me, and so this way I can get to those at the end of the presentation. A little history about sclerals. Why prescribe them? What's the big deal about these? Well, you can see here on my timeline that Da Vinci came up with the very first conceptualization about a scleral lens, but didn't really do anything about it. He was a little bit ahead of his time. But going into the mid-1800s, That's where you did really start to see a little bit of interest in scleral lenses. And coming down toward a little bit later in the 1800s, they actually were produced out of blown glass. The 1888, Fick described the use of the scleral lens with optics to correct vision, and here the following year you even had August Muller actually correct his own high myopia. So that may have been one of the first applications of scleral lenses to address ametropia. Things continue to move on, but you can see there down toward the end of the 1800s and into the early 1900s, you could see the real interest was centering around keratoconus. Now, moving into the little bit more modern history of scleral lenses, in the 1950s, after World War II, and the plastics that had been developed, corneal PMMA hard lenses largely replaced the glass-blown scleral lenses that had been used up until that time. And then corneal lenses really dominated for the next 30 years, obviously also bringing soft lenses in around the 70s. Until 1980s, they started to make their way back into the usage. You had in the 90s a few actual commercial brands made it to market. And then in the 2000s, they really started to become fairly commonly prescribed for some of the not only extreme pathological conditions there, but maybe even for high ametropia, maybe some of the dry eye type of scenarios. And so, yeah, they were starting to make their way into a little bit more general use. By the 2010s, they were definitely on the rise. Many lectures were presenting information, a lot of the about scleral lens, and a lot of the laboratories were coming up with their various proprietary designs, trying to get more of the practitioners motivated to use these things. And we really started to see them getting prescribed even for normal eyes. There was actually nothing unusual about the eye, yet scleral lenses were thought to be an appropriate treatment at that point. Now, coming down toward the latter part of the 2010s, and certainly now here in 2020, there was a lot more work done to actually start to qualify and quantify the scleral shape. Because these lenses do land on the sclera, it would be nice to know what's actually going on out there. And so we started to see some more technologies come along to actually be able to map the sclera. And as those technologies started to become more commonplace, some of the designs that were offered by the laboratories started to employ some of these particular issues, and certainly the physicians started to prescribe scleral lenses based on more of this information coming down from the scleral shape mapping. Now, today, what are some of the most common conditions sclerals are being prescribed for? And keratoconus certainly has to reign supreme right now, with keratoconus and pellucids being the top of the market share. You also can see some of the dystrophies and degenerations. Certainly post-refractive surgical patients can benefit by these, as well as ocular trauma cases. So the irregular surface has really taken the or I should say the irregular corneal surface has really been taken a bit out of the equation, and just go ahead and get the lens to land out on the sclera. We don't really have to worry as much about what's going on the cornea and trying to get the lens to center correctly and position correctly and be comfortable and all of that. Now, in addition to the keratoconus, probably the second most popular reason that these are being prescribed are for ocular surface disease. The dry eye, these things do really create a very nice artificial environment that the cornea will sit in that's wet all the time, and these people can really have an enormous amount of relief from their dry eye symptoms. On the pathological side, these certainly reign supreme. Things like graft versus host disease, the Stevens-Johnson, the persistent epithelial defects, and neurotrophic corneas, these really do benefit tremendously from these, and there really isn't anything else that can touch these lenses in terms of therapeutic value. for these types of conditions. Also, infectious sequelae leaving the cornea somewhat irregular, and certainly top on that would be something, for example, like a herpetic infection, sort of leaving the cornea in quite a state of disarray there, and giving that eye vision back again is certainly possible from the scleral lens. High ametropia is still added in there. Transplants. On the transplants, you'll see I have a question mark there, and the reason for that is transplants have to be taken care of sort of, each on their own merits, because the transplants have a lot of other concerns and baggage that they bring to the table, and not that scleral lenses aren't used for these, they absolutely are, but they have to really be used much more judiciously for these types of conditions, because many other things have to be taken into account. And then scleral shells are still being used for non-sighted eyes. So let's move on. So what are some of the benefits? Well, the optical benefits are obvious. You can neutralize ametropias, whether you have a, myope, hyperope, a highly astigmatic cornea, and even the presbyopes. Some of the laboratory offerings now are offering some multifocal designs, and so you can deal with presbyopes as well. You don't have to necessarily resort to monovision with scleral lenses. And then, of course, to neutralize some of these corneal irregularities, as we talked about the keratasias on the previous slide. Now, in the therapeutic benefits, you absolutely positively create a protective environment for the cornea and or conjunctiva, and certainly in ocular surface disease, this is really where these people can sort of have a sigh of relief from the symptoms that they get from these conditions. Do not take that to mean, though, that the condition is very simple to address. It's just that these devices really do work well in that environment to provide relief. It does stabilize the precorneal tear film, and it does create a reservoir so that the cornea can be lubricated consistently, and certainly in the last few years we've seen autologous serum tears being utilized even in the bowl of the scleral lens, so that we can get a very nice long delivery of that to try and heal some possible underlying pathology. Corneal neuralgia, that has a question mark, and there's certainly a lot more work that's starting to be surfacing on corneal neuralgia. Whether or not scleral lenses actually help these or not, I think the jury is still out. Certainly, subjectively, some patients have reported some benefits, but doesn't seem to be across the board that these people all have resolution to their complaints. Now, on the concern side, it's not everything is roses here. We have the physiological concerns of hypoxia. These lenses are absolutely less transmittable for their oxygen delivery to the cornea, and these patients do wear these lenses sometimes many hours a day. A 14 to 16 hour day is not uncommon, so we do have to concern ourselves with the possible level of hypoxia that may be generated underneath this. Increased IOP. Finally, after many years, study was released. It was a multi-center study about I think it was about a year and a half ago or so, that did show that the average IOP is raised on 5 millimeters of mercury at 5 hours of wear, and again, this was an average, so that means that some may have higher, some may be a little bit lower, but this is certainly a concern if you may have a fragile nerve and you're concerned about glaucoma. This may be a concern about putting something like this into play and raising IOP for 16 hours a day. That may be the proverbial straw that breaks the camel's back on that particular nerve. It does interfere with the normal epithelial turnover, and as a result, many scleral lens fitters had noticed over the years this almost like boggy epithelium, and in fact what it seems to be is that the epithelium that was supposed to be sloughed off just doesn't slough off as it's supposed to. And so whether or not that's a concern other than it doesn't look very good at the slit lamp, that remains to be seen, so we don't really know about that. We also have mechanical issues such as conjunctival prolapse and a possible loss of goblet cells, because these lenses do land on these the conjunctiva and do suck on, and there may be an actual mechanical insult to goblet cells, so that's a concern. Even on the dry eye patients, is it possible that we're fixing the symptoms and these people are much happier, but we may in fact be enhancing the problem over long periods of time, meaning years? The other problem here is also typically the environment underneath the scleral lens, which is what's contact with the cornea, is very nutrient deficient. We fill these lenses with sterile unpreserved saline, and that by no means is a replacement for a true tear layer. Tear layer function is meant to be in contact with a cornea to properly bring nutrition as well as to remove metabolic waste. And because we have more of a stagnant type of environment, this is something that we certainly have to be on the lookout for. On the practical side, patient handling has to be the #1 complaint from patients. Learning how to put these things on and learning how to remove them sometimes are very challenging for patients, and as such, many devices have surfaced to try and help patients along with this particular type of problem. I have seen and talked with colleagues that many people achieved fantastic results but gave up because they were not able to handle the lens. So this is a real issue, and it certainly bears a conversation with the patient at the beginning. Regarding vision, if they in fact really have horrible tear film, all you're doing with the scleral lens is you're moving it to the front of the lens. And so if that tear film is breaking up very readily on the front of the lens, these people will have poor vision performance from these lenses as well. You have a very, very large plastic area in the lens, and it's generally not very friendly to a tear film, unlike the corneal surface. And so this really can be a monkey wrench in terms of visual performance. Another real problem has come up with the irregular optics that are generated on the rear surface of some of the corneas, such as keratoconus and the like. Several colleagues have reported over the years that the patient seems to do better in glasses than they do in their scleral lenses. And the reason may be stemming from the fact that it neutralized the front optics, but did not neutralize the back optics or the irregular optics that were on the back of the cornea. And because that was still in the equation, they were really dealing with a lot of aberrations that were still present. And as of right now, we don't really have any way to address that with a scleral lens. And then lastly, the cost of the patient. These are more costly devices, and so that is a concern for the patients as well. In terminology, anyone entering this arena has known that this sort of seems to be a bit of a moving target, but you're pretty safe with these definitions, and you can see they're based basically on size. Semiscleral really is it's past the limbus and up to about 15 millimeters. The mini scleral is going to be 15 to 18 millimeters, and large sclerals are 18 to 24 millimeters. And certainly in dealing with the majority of the offerings from the laboratories out there, the mini sclerals certainly seem to be more of the dominating entity right now, both because it's a little bit easier for patients to handle and it does get the job done. Now, defining the parts of the scleral lens, you have the central portion, which is really devoted to the optics. The peripheral cornea, which is sort of how the lens is starting to make its way back to the cornea so that it can land. And we do have to be concerned with both prolate and oblate shapes. We have the limbal segment, which is how are we going to deal with getting across the limbus. One of the important concerns we have here because of the hypoxic environment, as well as mechanical insult, is you want the lens to actually land fairly close to the limbus, but not too close. On the other side, you don't want this really very, very high off the limbus because that may actually be causing a hypoxic situation on the limbal stem cell machinery. And then there's the flange and the haptic or the landing zone, and we have to really be concerned with how this lands onto the conjunctiva. We use terms like healing or towing, meaning that the lens maybe lands too close to the limbus and then lifts back up off as you're moving further from the cornea out toward the edge of the lens. Towing would be the exact opposite, meaning that it's kind of high more at the limbus, and then it's kind of digging in down at the edge of the lens. And then, of course, the asymmetry of that haptic to deal with what's going on the sclera. Now, historically, these started out as impression molded, as well as we had diagnostic fitting sets. And we basically just took a lot of trial and error, put lenses on, and went from there and got some lenses made. Today, we still have the trial and error. Many docs are still using some of the diagnostic fitting sets. We've gone back to impression molding again with iPrint Pro. That's more affectionately known as the Blue Goo. And then we have scleral mapping, which is where we actually will map out what's going on the sclera in great detail. And we can use that information both to sort of select our correct diagnostic lens, or you can go another step further and use some of the software driven design and manufacture approaches and actually get a lens that closely mimics exactly what's going on the underlying sclera. Now, in the scleral lens fitting and taking a look at the mapping, we have scleral mapping, and I included these three because it's sort of scleral mapping. It's not real true scleral mapping. The Medmont E300 corneal topographer is a Placido disc-based topographer. It's a fantastic machine, and has the ability to take these composite maps and stitch them together, but it really does end at the limbus, and so past the limbus, you still really have to extrapolate out what you think the lens is going to need so that you can get that to match up with whatever's going on onto the sclera. Do not be misled into thinking that whatever's going on the cornea will just continue out on the sclera. They really are two entirely different entities, and often they don't even look like they come from the same eye. Anterior segment OCT is nice. That tends to be a little bit more helpful once you get the lens on, so you can get a sense of how the lens is landing in any particular area. Again, you can also take some measurements and get some idea of sagittal depth, so that may help you in some trial lens estimation of what's going on there. And then you can just use your diagnostic set, put a lens on, and then estimate the sagitta at the biomicroscope. And don't sell short good clinical skills at the biomicroscope. They really can really solve the equation of getting a lens to perform correctly. Now, the true scleral mapping technology is really three on the market right now. You have the Eaglet Surface Profiler, which goes by the acronym ESP. You have the SMAP 3D, and then you have the Penticam Corneal Scleral Profile, which is the acronym CSP. Now, I'm going to be talking about the Penticam because I have been using this extensively for the last couple of years already. And so, Penticam, what is it? Well, it's a rotating camera. It spins around, and when it spins around, it takes optical slices through the cornea, giving you both corneal topography as well as tomography data. It images further back than the cornea, and you really can get into the anterior segment pretty nicely. There are three units, as you can see down on the pictures there. The basic, the AXL, the HR, they all have different strengths and weaknesses, and they have certainly different price tags associated with them. So you really have to decide what your real priority is in terms of your patient flow, as far as which Penticam is going to work the best for you. Now, in the world of scleral lens fitting, the HR and the basic are both compatible with the CSP software. The AXL is not. So if you're going to be fitting scleral lenses, the AXL is not the device for you because it's not going to give you really the information you need. Both the HR and the basic can, and they interface with the CSP software. What you can see on the screen here is a display of the CSP software. So I'm going to use my arrow here. On the right-hand side here, this is the actual cross-section that you can see. You can see the cornea, you can see the lid margin. This is a piece of the iris over here, and you can actually see the front of the crystalline lens over here. Down at the bottom over here is the information that we're more interested in with the sclera. Is you can see here's the limbus, and this is the information that we're really looking for because we want to get a sense of what's going on out where this lens is landing. And it's given this to you on both sides over here. Now on the top, you can see here, these are the actual scans that it took as it was rotating around, and the one that's highlighted, which is this one here at the top, it says 19 out of the 250 pictures that I took, is actually this cross section where the blue bar is going across. So that's the actual angle that we're looking at, and that's what we're seeing displayed down here at the bottom. On the left-hand side of the screen, these are the 25 profiles that were taken as it spun around. The center, which is color-coded gray, except for this one that's red, is color-coded gray. That's actually the central corneal data, and it's pretty much out to the limbus. So that's all the corneal data. The four colorful sections over here, you have the green, purple, red, and blue correspond respectively to the superior quadrant, the temporal quadrant, the inferior quadrant, and the nasal quadrant. And that's also displayed right here on this map. Now on this map here, you can see here's the central cornea, and it's out to just about 12 millimeters there. So you can actually see that really the gray data really is all of the central cornea, with the green respectively at the superior quadrant and these other colors over there in their respective quadrants there. Let's move on. This is in addition to that. Here's that coverage map that you can see, and you can see the coverage is quite good. You can see my coverage is actually extended out past the 16 millimeter ring on both sides there. This one I'm just about at 16, a little bit further, and this one I made it even a little bit further out there. So the coverage here is very, very good. And what the display also does is it uses a couple of reference spheres. Because the cornea is much more curved than the sclera, it's using a reference sphere for both the corneal data, right up over here that ends at this very harsh junction, and then the rest of it is the scleral data, and it's giving you the reference sphere that it's using. Here for the cornea, it's an 8.3 millimeter radii, and then the 10.5 millimeter radii, so that you can see that, and then gives you respective elevations off of those spheres, so you can see what's above the sphere and what's below the sphere here. Now, utilizing this map here on the left, you can see there's a lot of vacant data up over here, and if you look at the coverage map, you can see it looks like it's got some broken teeth over here. We really didn't get very, very good coverage on here, and this was one of the earlier attempts that I had. This is one of my patients, and you can see it was pretty horrible. As I started utilizing the device, you can see I got much better in terms of getting good coverage, and you can see I have a very, very good coverage map here, and respectively, you can see that the data really extends very, very far out on both directions. It is important if you're going to be fitting scleral lenses, you do want to get the data, from the captures right at the beginning to be very, very good data. Now, just to show you what's contained within these arcs, you can put your cursor down anywhere. In this particular case, I put my cursor down here and clicked on it. And this is probably a little too small for you to see, but there are a bunch of numbers here. So I just did a mouse over at a chord of 14 millimeters. And I've blown it up here so you can see what the actual values are. And what these are the sagittal depths at a chord of 14 millimeters, cross-secting through each one of those meridians. And so you can see how it's ranging over here. And you can see that I made this a little larger here, so you can see that the sagittal depth at 14 millimeter chord at that top line over here, it has a value of 3,361 microns. So that's telling you exactly where that is in space. Down here at the bottom on the temporal, I did the same exact thing, and you can see here I blew this one up to see 3,674 microns. And the thing that you should take away from this is that even at a chord of 14 millimeters, which is a fairly small diameter, we have a difference of over 300 microns between the superior and the temporal portion of where I took this cross section. Now on this one, I did it out at 15 millimeters because it does give you the display at 15 millimeters, and I just created a little chart here across the principal meridians that are displayed here. And so we got the respective values of the superior, temporal, inferior, and nasal quadrants at a 15 millimeter chord. And what we can see here is that at 15 millimeters at the extremes, we have nearly a 400 micron difference between the elevation of the inferior and nasal sclera. Down here, you're also getting the angle that the sclera is moving away at, and you can see there's a difference of 5 degrees, and in the world of scleral lenses, this is enormous. Now, I took that very, very same eye at a chord of 16.3 just to see how more asymmetric things would get out another millimeter, and in this case 1.3 millimeters out. And what we can see here is we're actually over a half a millimeter of difference between the inferior and superior quadrants. Notice it's not the inferior nasal that was dramatic like this, but it's actually the inferior and superior now. And we have a difference in angle of 8 degrees, which is enormous. It does also output an average, so it takes all that data and averages out, and it told us that we have a sagittal depth of about 4,800 microns at 17.1. So for example, if you're going to be fitting a 17 millimeter lens and you're looking for a trial set lens to start with, you certainly can pick at something at 4,800, and that should be pretty close to what you want in terms of getting that to line up on that particular eye. Now, what it also does, though, and I think this is very important to understand, is at 15 millimeters, the flat meridian was at 4 degrees, but at 16.3 millimeters, the flat meridian is actually at 16 degrees. So we've actually had a shift of where the flat meridian is. And this really does go to illustrate exactly how oddly shaped these scleras can really be. Now, this is the actual output that comes, and you would never really look at this. I'm only including this so you can understand a little of what's behind the curtain there. But you can see this sort of oval shape here. What that actually is a spreadsheet, and I kind of took an area and blew that up here, and I blew it up a little larger. This is actually all the data that it's capturing. And so at any given distance, right here in the middle, that would be the 0 point, because that would be at the apex of the cornea. These are the sagittal depths that the Pentacam was able to measure. And so you can see in excruciating detail exactly what the sclera is doing at any given point. Now, moving on, so we have all this data, big deal. It's an academic point? Not really. This is really a good starting point to understand how you can apply this so you can become much, much more efficient in clinical care. And so I've put up this particular case here so we can see exactly how do we take this data and use that to make our scleral lens fitting more streamlined in the office, because at the end of the day, that's certainly one of the more important things for us to do. We certainly can't spend 8 hours a day crunching numbers from a sagittal map. We need to be able to fit lots of patients and get them taken care of quickly. So this top left one here, this is on a normal cornea, and again, you can see the capture is very, very good, and you can see even the nice normal corneal shape there. And then down on the right here, this was a keratoconic eye, and immediately you don't need me to tell you that this is keratoconus. If you just take a look at the shape of this cornea, you can see that it's really not centered like the images over here. Now let's move on a little bit here. This is that keratoconus cornea, and you certainly can see how the visual axis has been moved, how it's much, much more curved down up over here. You can even see some of the thinning as well as even some of the scarring on this particular cornea, and this is just along a different meridian here. So let's move along. On this keratoconus patient, this was a scout topography of the eye, and this is the Pentacam topography and tomography that was captured of this right eye. It gives you the thinnest point down over here, and you can see it's at 306 microns. This is a fairly advanced keratoconic eye. And the display that I have showing here is giving you the front curvature map, which is very similar to the topographical map I have here from the Scout. But in addition to that, you also have down in the lower left here the pachymetry data, as well as the elevations of both the top and the front and the back surface of the corneas. And you can see here this back surface is very, very irregular, and it is going through the central portion. So if you were to take a lens and neutralize out anything that's unusual here on the front, and all of these optics came through, you can now see where some of the lens will actually fail to provide the correct visual resolution that we're trying to get. Now, on this particular fellow, he came in wearing a piggyback system. He had an Alcon Focus Daily on, which was a -50 power, and he had a small corneal GP lens on there. It was an 8.5 diameter. Power was 1475, and a base curve of 590, and he was getting 20/30 acuity out of that. I wasn't really all that thrilled with that particular fit. He really didn't have a complaint. He was comfortable. He was getting a decent amount of wear throughout the day, but I really was concerned about all that scarring that I was seeing there. And so I had talked to him about refitting him into a scleral, getting the lens off the eye, and possibly even improving vision. I do not do any trial lens fitting in my office. I do everything empirically. And so this spectacle refraction, I got a -1650 diopter. This here is the Wave software design screen. And I'm not going to go into Wave here, but what you need to take away from this particular screen, for those of you who don't utilize Wave or unfamiliar with Wave, is that in the bottom half of this screen, as soon as I get my cursor here, you can see this surface, which is gray, and then it's white out over here. And right now we happen to be looking at the nasal temporal meridian, the one straight across at 180. And this surface was actually generated directly from all that sagittal depth data that the Pentacam gathered. So this shape should be very representative of exactly what his eye looks like. On the top of that, you can see my blue arc, and that was the contact lens that I designed. And I designed in there a lens to land out here onto the sclera. You can see it's a diameter of about 15.8. The asymmetry of this lens is something that really is not accomplished through any other means other than something like Wave software. The only other devices right now on the market that can do something like that would be something like iPerm Pro, as well as, and I haven't had a chance to use it yet, is the possibly the Latitude lens that interfaces with the SMAP 3D. But with the Pentacam data, we have all of the actual corneal and scleral data here, and we can actually go to town and really make a truly customized lens land on this particular eye, specifying everything and anything I want to that's manufacturable by a lathe. You can also see on here, this particular graphic map over here is actually the front surface of this Wave lens, and you can see just how asymmetric all the power curves are going to be on this lens. Let's move on. I designed up my first Wave scleral lens. It had a base curve, and I put that in quotes because it's not really a base curve, of 6.290, but plus or minus 0.970. What that number refers to is actually a 2 standard deviation unit spread of all the curves through the back surface of this lens. So the better way you can think of that, we'll just round this number up to 1. So you can think of my curves on the back of this lens that are varying from about 529 to 729. That's what this is actually saying here. Diameter was 11.8, as we saw, and again, the power is reported also as a standard deviation, 2 standard deviation units. And again, we'll just round this off to 8 diopters. You can see that the power that's distributed on this lens from center to edge is varying somewhere between, let's see, 8, so it's about -3 to about a nearly a -20. Certainly a bizarre lens. This is not any spherical type of lens. Got the lens on this patient because I was using this first lens as a rehabilitation lens to allow his corneas to recover from the insult of the piggyback and corneal lens. The lens landed absolutely beautifully, 360 degrees. I had about 100 microns of central clearance over the cone. He already got better acuity out of my lens, 20/30 plus, and this was my over-refraction, which was basically nothing. And so you can see, without even putting a single lens on this eye, I already got 1 lens on this fellow, and we were done. I dispensed that lens. This gentleman actually was in earlier this week, which is about 7 weeks after I dispensed this lens. He's had about a 25 diopter shift in his cornea in topography. I didn't have a chance to include that into this lecture here, but that's how his cornea has actually started to recover now that it's been under the scleral lens for the last 7 weeks. He has maintained very good vision through all of that, and he's very, very comfortable. He's doing very well with it. So to summarize what we talked about here today about both the CSP software and the WAVE software, the CSP software provides sagittal data that's out to consistently about a 16.5 to 17 millimeter cord. Sometimes I can get a little bit larger, but sometimes it's even tough to get out to the 17. But that is very, very good for the bulk of the lenses that are actually being fit these days. The captured data can create a virtual model of the cornea within WAVE, and you use that as a reference surface. And so that reference surface can really design some truly bizarre shapes that can match up to the scleras, which can also be quite bizarre. If you're not using something like WAVE, and you're using, for example, a fitting set, you can use the captured data manually and then use that as a guide to choose one of your fixed designs, as long as you know the sagittal depths of those fixed designs at any given chord. It will also give you insight to just how much toricity and asymmetry is actually going on their underlying eye, both in the location and the magnitude of that. And so, for example, if you end up with an asymmetry, and I did actually present this case in the last webinar that I had done, it was actually a normal eye that had an asymmetry of about 1.2 millimeters. And so we're talking about not toricity, but on the extreme high elevated as well as the extreme low depressed portion of the sclera, it was over 1 millimeter different. And no, it was not regular toricity. So if you would gather this data with the CSP, you would know immediately that reaching for that spherical or even a toric haptic is probably not going to address the case very well, which in fact is exactly what happened to that particular patient that I was just referencing. He had been to several scleral lens fitters and none of the lenses worked well until he'd come to see me. And once I measured the sclera and saw the data, I was able to understand exactly why they had failed with all the scleral lenses they had tried. The one thing the CSP cannot do is it can't account for the spongy factor of the conjunctival tissue. And so these lenses do really settle. And so what we want to try and do is try and align the lens with the actual scleral shape, but take into account that we know they're going to settle down into the conjunctiva. Some a little bit more than a little bit, and some will actually settle quite significantly. And so sometimes I find myself going back and adjusting the lift centrally to create a little bit more because the lens actually settled down more than I was expecting it to. Okay, having the sagittal measurements at any chord given up to the 7 to 17 millimeter range in all those semi-meridians really allows you to empirically pick a lens much more appropriately, which saves obviously time in the office, but it also gives the patient a much better experience because you can get a lens on them that's very, very close right from the outset. And of course, if you're using this type of approach, in addition to being more efficient, ultimately you're going to actually get a better fitting lens, which will provide better vision, better comfort, and better physiology for the underlying eye. So if there are any questions, I'm very happy to take all those now, and I'm just going to leave this slide up for you guys.
Perfect. Thank you so much, Dr. Mahler, and thank you everyone for attending tonight. Just a reminder, on your GoToWebinar screen, there is a text box where you can enter any questions you may have. If you enter them now, I'll be able to read them off to Dr. Mahler. If you missed part of the webinar, or if there's anything you would like me to go back and review, you will receive a link to the recording within 48 hours of the end of this presentation. Dr. Mahler.
Okay.
For irregular or ectatic corneas, some doctors find more difficulty capturing the capturing the actual CSP scan on them. What tips do you have for those sorts of patients in getting good scan results?
Okay, I don't actually find that the degree of irregularity has any association with how difficult or easy gathering the CSP data is. Those don't really directly correlate. What does correlate, though, has to do with the actual orbital architecture. How big their superior brow is. Is their eye very, very deep set? Sometimes it requires a little bit of manipulation to be able to get the data out there because you have the lids in the way. Now, in the CSP capture, there are basically 5 captures per eye, and they go in order. You have the central capture first, which is generally that's easy. Just tell them to open their eye up wide and you do fine. You then get the nasal and temporal captures, and for the most part, I find just tell them to open their eye wide, and I can generally get those done pretty well. On occasion, either on the nasal or temporal side, you may have one of the lids that are dropping down a little bit too low out there, in which case I will have a tech help me lift up the lid out of the way on both of those scans. Now on the last 2 scans, which is the superior and the inferior, those can be brutal in that the lid and getting that out of the way really can be very, very challenging. Obviously, you really want to take your time to get those scans done well, but the single and most sage advice I can give is after trying virtually all types of approaches single-handedly, because I do the scans myself because I rely so heavily on the data, enlisting the help of 2 more hands and someone who can actually help you do the scans at the same time is an absolute must. There is no way that this data can be captured by a single person. So if you are delegating it out to a tech and you want CSP data, it absolutely is going to require 2 techs to do this, one to actually do the capture and one to manipulate the lids out of the way. Also bear in mind, especially if their tear films are compromised and you're trying to really get these lids out of the way for a prolonged period of time, while the scan itself doesn't take long, but while you're getting it set up, they can be very uncomfortable, and so you may need to use anesthetic just so that they're not fighting you in the instrument. And that's about it.
Perfect. And do you find the same thing for corneal scars?
Corneal scars are a whole different issue. Corneal scars can wreak havoc because this is an optical capture device and it's trying to take optical sections. And so if you have a scar, the Pennicam may have difficulty first determining exactly where the visual axis is. If the scar is more reflective than some of the tissues that we're trying to image over here, the Pennicam can be misled on that, and so these are absolutely things you have to be aware of. Unfortunately, the majority of my patients have scars, so this is something I deal with on a regular basis, and so I do know that it can wreak havoc trying to get good data. Patience, going back, taking your best scans, and knowing if you're in trouble, sometimes the auto capture will not be able to auto capture because the Pennicam can't tell exactly where the visual axis is. You have to be able to manually capture. And this absolutely, like I said, I do these myself, but if you're going to be delegating this to a tech, these techs absolutely need to be trained on that, not just, just hit the button and bring me data, because you're going to end up with useless data at that point.
Thank you so much.
Sure.
How do you determine the base curve measurement when you are making a lens, and how is it based on the sagittal depth selected?
I'm not sure what you mean by the base curve determination. As I had said, because I design a lot of wave lenses, base curve doesn't actually mean anything to a wave lens unless you happen to be designing a spherical optical portion. On a lot of these lenses, that's not what I am doing, and so the concept of base curve is kind of an outmoded one if you're actually going to be designing an asymmetric lens, even in the center. Now, if in fact you are designing a symmetrical lens in the center, but it's asymmetric surrounding, so it lands on the sclera correctly, then you can think in terms of base curve at that point. And what I generally try to do with base curve is I do try to match that up somewhere near where I can minimize the thickness of the lens, as well as minimize how high this lens is going to be sitting up off the eye, because I do want the lens to be fairly close to the eye to minimize any hypoxic issues on the underlying cornea.
All right. With wave sclerals, how much sagittal height difference would it take to make you change from a toric to a quadrant-specific design?
Oh, that's a great question. In the early days, I've been fitting wave sclerals now. It's coming up on close to 2 decades now. I used to fit spherical and quickly graduated to what would be referred to as a toric. Up until the point I started doing Pennicam CSP scans and started to appreciate just how asymmetric the sclera actually is, and even close to the limbus, it can be very asymmetric. Just as I showed on the case today, even at a core of 14 millimeters, we had over a 300 micron difference there in terms of elevation. That's significant, and that's a significant amount of asymmetry. Not that you won't be successful with the patient if you just design a toric lens, but I can tell you they're going to be way more comfortable and have a much better physiological performance if you can make it asymmetric. And so now it would be truly rare that I don't have an asymmetric flange. Virtually every wave lens I have has that's out on the sclera has an asymmetric flange, even if it's a small lens such as a 14.3 or a 14.5, where typically, you would think, oh, you could probably get a spherical on there. I don't even do a spherical flange on that. It would be an asymmetric lens.
Perfect. When determining the power of your lens, how do you determine that refraction that you want for your lens?
I will use every bit of know-how so that I can get the first lens very, very close. In the case I presented tonight, I utilized the lens he was wearing and the specifications of those parameters of the corneal GP. I matched that up with spectacly what I had refracted, kind of did a little fudging here and there to come up with something in the wave software that I thought was going to be really, really close, since we did have reasonably decent vision with the piggyback system he came in with. And you could see that fudging there, that was close enough to get me, within a quarter diopter. So that worked very well. If I have absolutely no data whatsoever, because these lenses are fitting so well, I actually have contemplated even considering putting a trial lens on so that I can get some over refractive data so I can have a better power idea for my first lens. And the reason I say it that way is because I've been fitting empirically now. Gosh, I tucked away the trial sets more than 15 years ago. They all have a thick coat of dust on them. So, but I've noticed now that the fitting on my first lenses are fitting so well that it's almost a shame not to have the power. Whereas historically, go back 3, 4, 5 years, 10 years, I knew I was going to be refitting the lens again anyway, so I figured I'll just use the first lens that I get as a diagnostic. So I've actually contemplated putting a lens on as a trial so I can get at least some refractive data, and that may be something that you might want to do.
Perfect. In terms of the variation, in terms of the landing zone on the sclera, do you ever get very flat or very steep scleras?
All the time. And do not think that the underlying condition is the reason why it's like that. In the previous webinar, I put up 3 cases. One was a perfectly normal eye, but had trauma to the cornea. So there was nothing unusual about that eye other than it had a penetrating injury. The second case was a keratoconic, and so we know it's a diseased eye. And then the third was a post-LASIK eye. And I put up the example, if I'm not mistaken, I think it was at about a cord of 16.5 millimeters. Now, based on that smorgasbord of eyes there, you would think probably the keratoconic would be the one that would be the most irregular, given that we know it's a diseased eye and the cornea is certainly misshapen, and we have collagen, dysfunction, and maybe that led to an unusual scleral shape. In fact, it was the normal eye that had the penetrating cornea that had the 1.2 millimeter asymmetry. And so I can say unequivocally that over the couple of years now that I've been using the CSP software, my mindset has changed dramatically about it doesn't matter what's going on the cornea. You have to measure the sclera on its own merits and do not be surprised at the degree of asymmetry that can be there. And clearly that's coming from the insertion of the recti muscles, as well as possibly some other influences as to why you end up with so much asymmetry out on these scleral surfaces.
Perfect. Thank you so much. All right. How does pinguicula or other abnormalities on the sclera affect the fitting of a scleral lens?
It affects it horribly. I hate pinguicula. I wish they would just go away because they certainly are the bane of the scleral lens fitters' existence. Of course, more serious than that are, for example, glaucoma, tube shunts. You might have some patch grafts that are up there. So there could be a couple of other abnormalities out there as well, and you have to be very, very respectful of those. The nice thing is that on the CSP software, you'll actually have those heights, so you can get a sense of exactly how high they are. So for example, if I'm measuring, and let's take the pinguicula because that's certainly one of the more popular problems, you measure the pinguicula and you could see that, at the limbal side of the pinguicula, we have a sagittal depth of, for example, let's say 3,700, and then you go over onto the pinguicula, and right over the peak of the pinguicula, you're at 4,700. Well, that's a millimeter high. That's not something you're going to be able to ignore. And so either you're going to be able to have to design the lens around that, plan on notching the lens out, or make the lens smaller so you don't have to deal with the pinguicula. Or if you really, really want to go, vault over the whole thing and then create a very, very large lens. So again, you're not going to impinge on the pinguicula. And the same would be true for the shunts and anything else that might be out there.
Perfect. Thank you so much, Dr. Mahler. That is all the time we have for tonight. Thank you for everyone in attendance and for everyone who sent in questions. Thank you, Dr. Mahler, for your excellent presentation and for your added discussion at the end.
Well, thank you all for attending. I appreciate it, and thank you for your help, Carver. Have a great night.
This concludes the presentation, and on behalf of Oculus, we wish you all a good night.